Good afternoon, everyone. This is Karen Kennedy from the Indiana Hospital Association. I'm joined here with Becky Hancock and Casey Hutchins, Madeline Wilson, and Shelby Hornback. Annette and others are traveling today, so just say thank you for joining us for this monthly HIIN call. We are going to focus on readmission reduction today, and Becky Hancock will be leading that conversation with us as we showcase one of our HIIN hospitals. If you could go ahead and advance to the next slide. I just want to go ahead just briefly talk about our mission as we do. Like to do so as we start off each meeting. You know, we are here to advance health in Indiana, engage and inspire healthcare providers, creating that culture of safety, and also creating reliable systems of care. And ultimately, what do we want to do? We want to prevent patient harm in Indiana. And so then moving forward, I just want to do just a couple housekeeping items. I just wanted to make sure to alert you to that an updated encyclopedia of measures. It was released mid-September, and we have been putting that in our HIIN weekly alert, but just wanted to point that out, that we do have some changes to that, and actually really the changes are really more to make some of the measures more optional, and then there were some edits to some existing measures, such as the ARC PSI measures, which really don't impact a lot of the hospitals participating with us in the HIIN, because we do upload those ARC measures for you. And then also wanted to point out too that the HIIN improvement calculator, there is a new version that was released in August. It did retire some of the measures on the HIIN improvement calculator, but probably one of the biggest things is that now you can select just to look back to the last quarter or the last calendar year of the HIIN. So you have the option of looking back to the beginning, but also, like I said, the last 12 months, which I think is really a great feature, because then it can show just that progress that you've made most recently. And then I wanted to discuss the data submission calendar. This also was sent to you electronically today in the HIIN weekly update. We have put together a data submission calendar through the end of the year. We will be updating that. That will show the data submission calendar through March. We're going to wait until we get to make sure we have good solid direction from HRET. We actually don't anticipate anything changing, so it's pretty much going to be a copy and paste when we go into January, February, and March. We are looking in October to have all the data through July for all the harm measures, and then readmissions would be through June. We're looking to have that all into CDS by October 14th. So that's all there for you. Certainly, if you have any questions, we'll have some time at the end, but also feel free to use your chat function and just type in those questions, and we'll get those answered throughout the call. I'm going to turn it over to Becky Hancock, and she's going to talk about improving patients and family engagement first, and then she's also, then I said, she's going to guide us into some conversations about some other topics, but then focusing on readmissions reduction.
Thank you, Karen. I just want to mention that we will have the slides and the recording after this presentation, and Casey will take care of getting that hyperlink to you that we'll have on our website. Part of that is because there are some hyperlinks of value within our PowerPoint, and just so you know, a couple presentations we did were just audio, and this one does include a PowerPoint content for you. So, and thank you for keeping your phones on mute during this session, and we'll open them up at the end for a Q&A as well. Currently in front of us is the current state of advancing patient and family engagement in Indiana, and our last report on that was through August 2019. And what this particular graph shows is that we are really faring well for better than the nation and the HRT in general, HRT hospitals, 1,600 of them versus the nation, which is about 4,000 hospitals, for PFEs 1 through 4. And our goal for this is to have 80% PFE metrics hit per hospital. So that's 4 out of 5 of the PFE metrics that we expect each hospital to be able to say, yes, we are meeting those metrics. And so the last 2 are the ones that we're not at 80% yet. And PFE4 is an active patient family advisory council, or one patient on a QI or PI team. So that's the one that we'd like to give some serious thought when we do our next operational metrics report, that if you even have one patient on a QI team or an active PFAC committee, then you can say yes to that. PFE, and that one's at 63% for PFE4. PFE5, which is reporting to your board on PFE, we're currently at 53%, and we really want to get more on that as well. But again, we're looking for 8% compliance, or 4 out of 5 PFE metrics being met. At this time, we do not know when the next operational metrics will be submitted for the HIIN. However, we will let you know once they let us know. That is a work in progress. But again, PFE is still a high priority for CMS, patient family engagement, as well as for the HIIN, because all of our work should be patient-centered as we proceed through across the continuum of care. The next slide here is an initiative called Age-Friendly Health Systems Collaborative. And this Age-Friendly Health Systems Collaborative is a coordinated effort by the Institute for Healthcare Improvement, the Hospital Association, American Hospital Association, as well as the John Hartford Foundation. John Hartford Foundation participates in a lot of geriatric-focused content for hospitals, and this will be starting cohort number 3 of Age-Friendly Health Systems cohort. The focus of that is on the 4 M's of an age-friendly health system, and those 4 M's include what matters to the patient, mobility, medication, and mentation. And as you can imagine, these are all topics that older adults can very quickly get into a great deal of trouble with, and that we need to be on top of when changes occur in mobility, medication, and mentation. And also the question of what matters to not only the patient, but the caregiver. The goal of this collaborative will be to pick about 2 metrics that you want to work on within the 4 M's of an age-friendly health system, and work within the structure that will be provided by the guides for this particular collaborative. So we encourage you to sign up for that. And on the particular slide that I have in front of you, which is slide 8, there is a AHA Action Community at AHA.org is the hyperlink to get to that. But if you Google Age-Friendly Health Systems and Institute for Healthcare Improvement, you will, and the John Hartford Foundation also has a wonderful video describing the collaborative, and you can learn more about how to do this as a hospital or as a health system, and learn more about how to do this as a practice to improve care to be an age-friendly institution. And I know that we all want to take good care of our older adults, and this is a great opportunity to participate in this collaborative. And the video on the John Hartford Foundation website can guide you through what the mechanics are of that and the involvement expectations. It's not a huge amount of involvement. You determine your own operational metrics and improve care at the rate that you can within your institution. So a great program that we wanted to mention to you as it gets expanded for cohort number 3. So they will have experiences from cohort 1 and cohort 2 available to learn from. The second major initiative that we're sharing today is a performance improvement collaborative that is being featured and run by our HIIN. The purpose of this collaborative is to go with some overall design metrics around performance improvement structures within your hospital, to take a step back and instead of looking at our individual harm topics that we have, this is focused on sustainability of PI initiatives that you are already doing. So what it says on the slide is the operational time is from October of 2019 through March of 2020, which happens to be the extent of our HIIN extension as it stands right now. So they're asking for a 6-month participation starting in October, and it's to help hospitals reduce hospital-acquired harms and improve patient safety and the quality of care across the system. And some of the harm topics will be included. You'll be able to pick, again, like the previous collaborator I discussed, pick your own metrics that you're going to work with. And as you can see, there are several cohort group start dates, a total of 6 start dates throughout the month of October, but we are in group 2 with a start date of October 15th. So that will be the startup collaborative discussion, but they want us to have our hospitals complete a survey by October 11th. And it's a very, very simple survey, about 6 questions about what your hospital is like. It kind of just gets your name on the list for the communications more than anything else. So the hyperlink will include the survey. It'll also be available on the HIIN website. And again, please participate in this as well, and it will be a major initiative of our HIIN content with peer-to-peer sharing and also focused coaching and guidance on small tests of change as we have tried to ascribe to thus far with coaches and national subject matter experts. Our 4th bucket of care within our mission is to improve community health. And with that, we want to mention our sepsis and community impact of our sepsis program that occurred in Sepsis Awareness Month in September. And these are just a few of the slides, pictures that came in across our institution about the work that's being done out there for sepsis awareness in the communities. I was at a coalition meeting this morning, and there was a robust discussion around the need to get the non-clinicians educated as well about sepsis, and that was one of our initiatives that we asked for, to educate the communities as well as the extended care facilities. And one suggestion was to make sure all of our hospital employees are educated as well on sepsis. And I know that many of you had fairs within your hospitals, so please send us all your pictures that you have and a brief description of your activities so we can help understand the impact that our Sepsis Awareness Month had across the continuum of care out in Indiana. So these are a few of them. In fact, several of these presented today, a couple of these presented today at our South Central Coalition, and we thank you so much for your participation and your great pictures. Hopefully you see your smiling face up there. If not, send us more of your pictures and we'll get a slide presentation going for all of those. Just great, great work. I also got followed into the bathroom by one person who was so excited about the toothbrushes prepared for our HIIN to say, oh, we love our toothbrushes. I'm like, great, I still got to go to the bathroom. But it was not, it was a great comment from them to be so excited about the connection between oral health and pneumonia prevention in the way of sepsis prevention. So thank you very much for using the items that you received from us and celebrating sepsis as an opportunity for prevention and community education. Now we want to move into preventing patient harm topics. And one of the topics that we're doing is chest training, and Shelby's here in the room, so I'm going to ask Shelby to mention anything that I don't cover here on the slide. But in participating in hospitals, we have the opportunity to participate in our 2nd cohort of chest training, which is Certified Healthcare Environmental Services Technician. And this allows our environmental services technicians in a train-the-trainer type format to learn the skills to be a CHEST certified technician for environmental care. And there are many topics, and it's a 3-day program on November 4th, 5th, and 6th here at our IHA office. Class size is limited to 40 attendees, and the training is at no cost to you. We're covering travel, lodging, meals, and there is an application deadline for October 23rd. You can email Annette Handy at ahandy@ihaconnect.org to register. We are not covering travel, lodging, and meals for those 3 days. So those are, thank you, Casey. So those are the responsibility of the attendee or the respective organization. And this was a fantastic program. So much excitement in the room, and cake to celebrate at the end because everyone was so excited, and especially the environmental services who are so much a part of our team, an integral part of our team, that we want to celebrate their work and help them provide clean environments so that we can keep our environmental improvements as well as our host improvements to prevent infection within our hospitals.
Becky, one thing I might just want to make sure and point out with this CHEST training opportunity is when the individuals leave that day, they are actually certified to go back and do training. So it's a train the trainer, and that we have the same 3 facilitators coming back. They were extremely well received when we hosted this in May. We were able to do that through a grant that we have with the Indiana State Department of Health that works with rural and critical access hospitals. It was extremely gratifying. You can imagine after 3 days of a training session that majority of people would be like exhausted and just ready to go home. This wasn't the case. It was probably the most energized room I've ever seen in a training session. They were high-fiving everyone. It was just really great. So please look into this to have someone from your environmental services team to join. We did actually have quality director and infection preventionists that were in attendance as well.
So that really helps us provide joy in the healthcare workplace at the meeting, and so it was actually fun for everyone. So thank you, Karen. Anything, Shelby, anything to add on that? All right, thank you. Now we're going to transition now to readmissions. And one of the reasons we decided to pick readmissions to focus on is we had some initial gains within the HIIN for readmission reduction that occurred between essentially 2014 and 2016, from our baseline to 2016. And all of our gains are slowly being resolved here, so that we've gone from meeting our goal back in March of 2017 to actually just, which would be 12% reduction, to just having a 3.6 reduction in all-cause readmissions for our HIIN hospitals at this time. So as you can see from this graph, we're currently challenged with an increasing readmission rate. So we just wanted to call this to your attention, aware of the increasing comorbid conditions that are coming through and increased complexity of the patients. But what we're going to do is do a little more focus on readmissions. But I wanted to show you what the data looks like so that you're aware of it. And if I were to go in and look at many of the hospitals, you would have a very similar curve. So just asking you to revisit that, and we may have an opportunity to do a little discussion at the end of this about what are your primary barriers with all-cause readmissions at this time. So of course this is not just Medicare, this is all-cause. And that was out of your HIIN improvement calculators, but you can find the information for your HIIN within the report section of the HIIN CDS website, the data system, and go to reports and pull up the indicator for all-cause readmissions. And then you can filter for Medicare readmissions and look at the two to see if your Medicare is what's driving your readmissions, and oftentimes that is because it's the largest volume of patients. But what I wanted to do was to also take a look within our hospital, our IHA system of DataLink. And all quality directors have received the opportunity to log into DataLink and take a look at how your hospital is doing on a number of different indicators, including HRQ indicators, readmissions, sepsis mortality, and one other issue. But within readmissions, this is what the graph looks like for Indiana. So in Indiana, including all hospitals, we've gone from 9% in first quarter of 2016 down to 8 to 8.12% readmissions for all cause in third quarter of 2018 to fourth quarter of 2018. So this is up through 2018 data. If you go into DataLink, it actually goes through first quarter of 2019 at this time, so a little more recent. So this is what it does show some reduction, but I just want to make sure you were aware of both data sources within which to assess your readmission rates. So this is Indiana statewide. Our next graph here out of DataLink shows that between 2016 and 2018, our total readmission volume went down by about 10,000 across the state of Indiana, which ultimately is good. And also, our discharge patients went down by about 4,000 from 2016 to 2018. Now, that's just total volumes of patients, and then back to our rate, which showed about a 1% reduction. But we are having a decrease in hospital admissions, which has a lot of a ripple effect across our state. But just so you know, that these are the numbers that you can take a look at within the readmission packet in DataLink. Now, this is another piece of information that we pulled out of our inpatient discharge study data, and I think you'll find this very interesting. And this is not a particular part within data link at this time, so this is kind of just an overall state view of what are the top most frequent DRGs that we are seeing as readmissions. Now, what we do know is that there are many, many cross-cutting measures that we do for all patients, irrelevant of what their diagnosis is, in order to have safe transitions home to avoid a readmission. However, when we're looking at some subpopulations, it's interesting to know which of your patient diagnoses are most at risk for readmission. What we also know is that LACE scores don't often get into the details of a diagnosis in order to, a lot of hospitals are using risk standardized LACE scores to determine if they're high risk for readmission and pulling in discharge planners, particularly the high risk patients, which is still a good thing to do. But right here what it shows is that our 10 most frequent DRGs, number one is sepsis without mechanical ventilation. Second is heart failure, which is not a surprise. And third is COPD, but fourth on our list of most frequent readmissions is psychoses. Now, we had a discussion this morning in our South Central Coalition about behavioral health in the ED and the needs for clinical staff, social workers, as well as nurse practitioners, and to have a knowledgeable staff, inpatient staff that can handle some of the behavioral health issues that are occurring. But I think it's very interesting that psychoses is the number 4 most frequent DRG. Fifth is pulmonary edema and respiratory failure. Sixth is major joint replacements. DRG 470 is the sixth most frequent DRG for readmissions. And seventh is esophagitis. 8 is renal failure. 9th is simple pneumonia and pleurisy, which of course simple pneumonia can lead to sepsis, as you are all aware of, where I've said that a million times. And number 10 is septicemia without mechanical ventilation and without major complication code. So this is the frequency within which major DRGs are coming into the hospitals for readmissions. On the right-hand side of this graph, we see all Indiana readmissions and where they're coming from, what was their discharge status. And the most common discharge status for the readmits was home or self-care. And I think that when Greene County, and Vicki McHenry here presents in a moment, this is comparable to the data that they saw with their hospital, and so the interventions that they did in their hospital to address home or self-care patients who were being readmitted. That's 109,000 roughly readmits from home or self-care. And second is skilled nursing facility with Medicare certification at 35,000. So more than almost 2.5 times our patient population are coming from home or self-care. Third is, again, home under home health at 26,000 essentially. So home or self-care and home under care of home health are our most frequent readmissions. And of course, those are, you know, went home with home health because they're higher risk anyway, but Vicki's going to very eloquently describe what they found out. And then hospice and inpatient rehab, then custodial supported care, then cancer care, then hospice home care, and Medicare acute long-term care facilities, and Medicare swing beds. So this may be reflective of what you're seeing in your hospital as well, but this is what we're seeing in the state as far as special needs population. And now what I'd like to do is turn it over to Vicki McHenry from Greene County General Hospital in Linton, Indiana, who presented to our Central Southwest Coalition on the initiatives that they have done from 2016 to 2018, making improvements to reduce their readmissions, and we'll show her graph and get her content here in a minute. And I just included a nice picture of the volunteers here because my aunt, who's 99, I think, is right in the front and center with a blue medallion around her neck, participating in one of sitting at their front desk every time I walk in at age 99, so a big cohort of volunteers. So Vicki, are you on the line?
Yes, I am.
Great. So I turn the microphone over to you, and thank you for your presentation today.
Okay. I guess, as you can see, we're based in Greene County, Indiana. We are a critical access hospital. Although we are critical access, we run a lot of outpatient volume and still quite an inpatient too. We're one of the largest counties in Indiana, so therefore we are utilized a lot by our community. We kind of got into the readmissions monitoring a little bit late in the game, but Jill Raines, who's the director of quality, and I, when we both assumed our new roles, we officially started monitoring our rates of readmissions in 2016. Before that, it kind of been felt like since we were critical access, it wasn't as detrimental to us as it is to some of the PPS hospitals. However, what we soon found was a lot of the private payer insurances started following the same guidelines with their readmissions and penalties as what CMS did. Our readmission rates in 2016 in-house is what we were monitoring at that point in time were 6%. So we really weren't that high to begin with. But then Jill came to me, I can't remember what the original percentage was. Becky, I don't know if you remember, but we had to have a certain percent of reduction in that to meet the standard.
There's a 12% reduction goal for the HIIN.
Yes. So as you can see on this graph where the arrow is, in July of 2017, we specifically started monitoring just our in-house readmissions because we felt like if we could get a good grip on those, then the ripple effect, it would affect the ones going to other hospitals post-discharge as well. So in July 2017, we had a rapid improvement event solely based on discharge of the patient. And we had multidisciplinary people in the room from pharmacy, respiratory, nursing. And what we started with was basically the discharge instructions for the patient. And we had pharmacy read the nursing part, nurses read the pharmacy part, people that aren't typically used to just seeing the information and making sure that if they were a patient, would I understand what these instructions said? So going from that, we made changes to our discharge instructions for our patients. And then we spoke with the CEO, and I had an idea of restructuring what we had historically had was just a UR nurse and a social worker Monday through Friday. And we structured it into a case management department where there would be 2 case managers here Monday through Friday from 7 to 5:30. And they worked every 3rd weekend because what we felt like was a lot of these cases were coming back in on the weekends, and things were kind of falling through the cracks on the weekends. So we got some weekend coverage started at that point. And we kind of changed the structure of that as well because like Becky said earlier, we wanted to focus more on the psychological behavioral health stuff that we are struggling with in our emergency room. So the social workers' main focus is now is a lot of work in the emergency room. And the case managers are handling most of the stuff on the floors. So we did have that change in our model, I guess I would say. So some of the steps that we originally implemented, if you want to change to the next slide, Becky. We started doing the scheduling of a follow-up appointment with family physician post-discharge to help patients stay compliant with that. One of the biggest things we did, we call all of our patients inpatients and observations 24 hours post-discharge to ensure that whatever transition plan that we set up, that it's working effectively, or if they went home without services, that they had their prescriptions filled or had went to the follow-up appointment, or if we lined up home health care, that the home health care agency, if they had heard from them or if they had arrived that day to be seen. We started calling all patients that were classified as a high risk from a high risk screening, a minimum of once a week for 4 weeks to get them through that 30 days, and just the case managers touching base with them each week to make sure things were still going well. And I would say this probably had the biggest impact because a lot of times they would call us more than once a week, and the case managers would assist them with maybe getting into the doctor sooner if that's what they felt like needed to happen. So I think these calls probably were the most impactful. And the way we would preface that is, which I have a little bit later in the slides, but the case managers see every patient every day. And in that conversation, they use consistent worksheets so that everything is addressed by all of them the same. But they'll tell the patient, you know, I'm going to be calling you once you're discharged. So there's consistency, and the patient will be expecting the call and will hopefully answer the phone. We started scheduling discharge planning meetings with patients and families for any patient that was classified as high risk. Prior to that, we had only had discharge planning meetings with the patients for our swing beds, which is a skilled level of care. But we started doing that with the high risk to hopefully make it a more planned and smooth transition with having everybody involved. Our highest readmissions, and it still continues to be, are the ones that are discharging to home without any services. So we started, if we had a plan of care of what we thought the patient would be best for, and maybe they weren't in agreement with whoever was speaking with about it, we tried it with a different approach of maybe having another case manager go in and approaching it just a little bit differently. And sometimes it's a personality thing, and they might be more compliant with the other person that they were talking with. We have an interesting setup here. We have what we call a sniffologist, but it's a physician that is employed by our hospital that is the medical director at several of our local nursing homes, and he sees pretty much all the patients in the nursing homes. So when we have a discharge to the nursing home of any high-risk patient, we now have a way that we send the discharge instructions to him via a secure email and to his nurse practitioner who helps him. So that he knows that these are patients that we're watching, and you know, they're high risk for being readmitted, and he needs to take extra precautions of maybe trying to have things done more on the outpatient basis versus just having them sent directly back to the ER. And this is something else that has been really impactful on preventing the readmissions from the SNF. So after 2018, we actually got our readmissions in-house down to 3.6, which was a 50% reduction from 2017 after we implemented those measures that I spoke of. Again, what we noticed was our high percent of discharge to homes. So in 2019, our focus is for discharged inpatients only. We started making up to 3 attempts to call them on that next day or the day after that if they would not answer. Again, talking to the patient we're going to be calling. And so far, we have had a lot of compliance with that. However, like Becky said, we have had a little bit of an uptick in our readmissions again this year by 1 to 2%. And it's the complex comorbidity patients and non-compliance that we're struggling with. So other things we've done this year, historically we had not had a multidisciplinary meeting each day about each patient. We started doing that in May of this year, and we're including we have one hospitalist, and we're including him in that, and trying to have discussions in that meeting about readmission risk. Again, case managers meet with our patients every day, talking to them and with a daily update of what the plan's going to be. They also help the nurses with reinforcing education of things we're working on, education about their medicines, wounds, so forth. Another thing we did that has been rather impactful, we met with the director of our emergency room and discussed with him what our readmission goals are. And a lot of the people are, you know, returning to the emergency room, and of course it's usually busy down there, so the easiest thing to do is just readmit them right back into the hospital. So we discussed a lot of other options with them, and then with social work being there, trying to come up with placements from the emergency room, or utilizing our swing bed, like if they're not meeting an acute criteria, but they discharge home with pneumonia, but they come in back with weakness. If they've returned within 30 days, we'll utilize our swing bed to address that need. A couple new measures that we have just started actually. We're trialing having our social service workers here on Saturdays from 8 to 6 because there just still tends to be this huge demand in the emergency room and running into a lot of issues on the weekends. We're also trialing a new high-risk screen that we haven't used. It's through the MCG program. We're going to trial that in October, kind of see what data we get out of that at the end of October, and then go from that and decide if we need to try to change our initiative of what we're looking at and what we need to be working on. It's a little more strict high-risk screen than what we have been using, so I'm sure we'll have more trigger, but we're trying to again, to figure out what these patients discharging home, where we can focus more. And then lastly, we have a continuum of care meeting each quarter. And we invite SNF, home health care, hospice, and we've been having discussions on transition of care with all those at that meeting. And just trying to figure out ways to smooth the process. And some of that's involved, like there's specific information that they need that we're sending them, but they didn't necessarily know which form it was in the whole packet that we were sending them. So just bringing attention of where they would find that information in our records when we send it to them. Things like that. We've also discussed transportation and ways to take care of issues that we're having with that. But it's definitely still a work in progress, and hopefully we can get our numbers back down to where we were at last year. And that's all I have.
Thank you, Vicki. You hit on a number of very important topics that I think all hospitals have looked, not all hospitals, can consider in their operations improvement, performance improvement for readmission reduction. A few things is having the sniffologist involved, and as well as social services and doubling involved on Saturdays. I do want to mention a question here is, how do you define high risk, and how many patients do one of your case managers see in one day? Jill mentioned on the chat room too, you use the Anthem definition for high risk, and that you have 2 case managers through the week to split the patients. And so 2 case managers is double what you had at the beginning, correct?
Correct.
Yes, and so they split the patients. The average census is 8. And if case management is not at work, our social workers see the patients. So Jill Raines, thank you for responding to Abby Morgan in the chat. And I encourage you to put any more questions in your in the chat room that you have, or we can open up our phone lines as well. But I just want to point out a few things that Jill mentioned, was having the sniffologists communicate. And I'm going to mention these things because these are themes that I've heard in transitions of care programs from a few of the hospitals that have been involved with presentations that I have attended. And one is making sure that communication gets to primary care, and you're using your sniffologist as well. You also mentioned in the previous presentation that patients were going at home and refusing home care, but then after 3 to 4 days at home, they were realizing, oops, I guess I do need some help. And at that point, you were better able to implement home care for them, which in the long run would prevent that readmission, correct?
Correct. Yes, our case managers will hand out their business cards to the patients, and and then they're also following up with them on the phone. But they'll tell them, if anything comes up, give us a call back. And we have had multiple occasions where we went ahead and set up home care, made the referrals and stuff after the patient had already been home for several days.
And that you're trying to contact the patient with 3 initial phone calls to get in touch with them, as opposed to 1 or so and saying, oh, we just couldn't get in touch with you. You're making sure you continue the effort, which I think is very important. I don't see any other questions in the queue here on the chat. We can open up for a moment, open up all the chat lines and see if you have any questions that you would like to address to Vicki. I want to note that in 2016, their readmission rate was 6%, and they reduced it to 3.6%. So their readmission rate at that time was not high compared to the benchmark, but they wanted to meet their 12% reduction goal and to improve the care at their hospital, which we've asked all hospitals to use their own benchmark to get to that 12% reduction. And congratulations to Green. Are there any questions out there or discussion points that you would like to add to this initial presentation? And I will mention that I was going to have Schneck do a recorded presentation that they did for South Central Coalition, but it was 25 minutes and we just couldn't fit it in with the content we had here. So I will set up another opportunity for Schneck to present on their transition care program too. Harrison County is also presented that I'm aware of, and others as well, but we'll get some other opportunities for sharing readmission reduction processes on the books for you. So any comments from the bleachers here in our room, the back bleachers? Any comments from anyone out in the field there that you would like to comment on or ask questions of Vicki or make comments on your own initiatives that you've done that have been especially effective for readmission reduction? One more question here that we have coming in from BDXM 15. What were the main reasons patients felt they needed home health care after discharge that was not addressed initially?
Several of those patients were COPD patients, and we ended up doing like a trilogy device at home for home health care and Lynn Care with that. Some of them were like they went home and they were weak and they were realizing they were struggling getting around. So they wanted to get therapy at home.
Thank you. Thank you. Just a reminder that all lines are open at the moment, so please mute yours if you're typing in the background or speaking with those in your room as we were accepting comments. So I believe we answered BDM 15's question. What were the main reasons that they were being readmitted? Any other questions you would like to chat in or address in the chat room or through the phone lines for those who may have just called in?
I have another question for you.
That's it. Very good. Well, Vicki, we thank you very, very much for your presentation. And again, the slides do have the list of the initiatives that she put in place. She and their team there, including Jill Raines at Greene County Hospital, to improve care for their community, which is indeed the largest county in the state that they serve, geographically speaking. Second largest? It's the largest.
Allen, I think.
Allen's larger. I stand corrected. All right. Thank you, Casey, who is from Greene County and knows the details.
That was a fair queen question, in case anybody's interested.
Very good. All right. So I will address the final slide now. Karen, do you want to address this, what we're looking for regarding our communications feedback and how we communicate with you and what we can do to improve?
Yeah, so as far as the HIIN goes, we send you the weekly HIIN alerts, and then we have these monthly HIIN calls, and then we also include HIIN information in our patient safety newsletter, which that particular newsletter goes out to a broader group. So we just wanted to kind of just pause for a couple minutes to see if anyone had any feedback for us, if these mechanisms work well, if you have any other ideas or suggestions on how we can best communicate information to you. And obviously then we do have, one-on-one communication that's happening throughout the course of the month too. But right now we're just kind of talking about that broad, broad audience communication. Does anyone have any comments or thoughts?
You can chat in your pleasure or displeasure with any of the options, or I believe the phone lines are open at the time and you can speak up.
Okay. Well, think about it and feel free to reach out to any of us and, you know, provide that feedback to us one-on-one. We would greatly appreciate hearing, you know, what's meeting your needs and how we can do better.
We're always up for opportunities for improvement, performance improvement within our communications and how we work with our hospitals here. All righty. Anything else from any comments from within the room here? Opportunities? All right. Upcoming events. In addition to the 2 opportunities for the PI Collaborative through HIIN, as well as the age-friendly initiative that we mentioned, October 16th to 18th in French Lick is the IONL. It's now Indiana Organization for Nurse Leadership, not Indiana Organization for Nurse Executive. They changed the E to an L. Their fall conference. On October 24th and 25th is our IHA annual membership meeting here in Indianapolis. On the 24th is the first day of that is a concurrent meeting on the Healthcare Management Summit, and it's our 2nd annual presentation for healthcare management that we present parallel with our IHA meeting. And the registration for that healthcare management on October 24th in Indianapolis is free. So we encourage those of you who want a day of healthcare management conversations at no cost to register for that. I mentioned on November 4th, the Indiana Center for Nursing is having their summit here in Indianapolis, and you can go on the Indiana Center for Nursing website to register for that. It's not, I think it's $30 to register, and there are a number of nursing poster presentations and podium presentations from research and nursing across the state of Indiana that are all from our hospitals. I know there will be a presentation on culture of safety. There will be a presentation on human capital for nursing managers, and another presentation on nurse resiliency that I'm aware of, as well as a number of other poster presentations. I found this to be very educational and a great opportunity for networking over the course of the last few years. On November 7th is the APIC Indiana Fall Conference in Greenwood, and details are available soon. And November 20th and 21st is our ISDH Infectious Disease Summit here in Indianapolis. In December is our Infant Mortality Summit as well, that is not on here, but the registration is open for that particular summit that you can get to through Indiana State Department of Health's website or through our website as well. And we look forward to working with you again. Here is our team with all of our contact information, emails, and phone numbers should you need to get in touch with us if our communication is inadequate, insufficient, or you have more questions. And just happy to mention again that Catherine Bosma in the bottom right there is a new member of our team representing maternal and infant quality improvement as our new advisor working with the State Department of Health and all of our hospitals across the state on maternal and infant mortality, and our goals to reduce that in the state in a great way and get us off of the list that we're on of not doing well for that. So thank you again for your participation, and we look forward to working through our HIIN as well as our coalitions here in the state of Indiana. And thank you all for the work that you do. I think we're humbled by all the work that's done in our hospitals on behalf of patient safety and harm reduction. So keep up the great work and let us know what we can do for you.